Hello, everyone, and welcome to today's podcast. My name is Nishanth, and I'm a Director of Strategic Partnerships and Marketing at Innovaccer. And today I have the pleasure of introducing all of you to Mark Anderson. Mark is a medical futurist and a renowned thought leader with a wealth of healthcare experience. Over the past 40 years, Mark has been the CIO of multiple different IDNs, as well as the CEO of an IPA, sorry. He is here today in his current capacity as the COO of the East Texas Health System, as well as the CEO of the AC Group. He's here to talk to us about the ongoing shift from fee for service to value based reimbursement and its impact on the different players in healthcare. Hi, Mark, and welcome to this podcast.
Good afternoon. I'm glad everybody was able to join us today.
Great. So, Mark, just to kick things off, do you want to say a little bit about, value based reimbursement, or shall we jump into a few questions that I have lined up for you?
Well, I'll do a quick overview. As most people know, the government and the healthcare plans have decided that we need to start moving towards a different reimbursement model, more around quality and outcomes and reducing costs instead of fee for service billing. So today we're going to talk about what the effects are on that and what does it really mean to the healthcare systems, the payers, and the patients and their family out there. So I think this would be a great conversation everybody needs to learn about.
Great. Thank you, Mark. So, just to kick things off, why do you think all the healthcare organizations should adapt to value-based reimbursement, or VBR as we call it?
I think that's pretty easy. As I mentioned, the healthcare costs have been increasing every year, and it's 4 times faster than the gross national product. We can't keep this going. Think about that. Since 1960, total healthcare spending has increased over 818%, while our national wages have only increased 16%, and the GDP has only increased 168%. 4 times faster growth in healthcare spending than anything else. Somebody needs to do something about it. And we know when we compare the United States healthcare to the other countries that are the developing countries, on average, we're spending almost $8,000 per person per year for healthcare. And that adds up to about $2.5 trillion. And in comparison to the other countries that are out there, they're only spending $3,200 per person for healthcare. That means we are 150% higher per capita than anybody else, any other country out there. And can we keep doing this? No. And that's why I think the government came up with this program about 5 years ago called Accountable Care Organizations. And they really want to shift from fee-for-service billing, where there is no real financial incentive to cut costs or to improve outcomes, to a quality-based reimbursement system where care providers are financially incentivized to improve health and outcomes while lowering costs.
Interesting. So, Mark, what you're talking about requires quite a bit of a mindset shift, right? From fee-for-service to value-based uh, reimbursement models. What is the most important factor to, help begin this shift, if you want to call it that?
Well, you're asking what do the healthcare organizations need to get prepared for during this shift?
Sure. Yeah.
I would say, yeah. So I would say the important part is we already know Medicare is moving 50% of their payments to this alternative payment program, as they call it, which is based on value and outcome. And it starts in October of 2017. So it's just right around the corner. And we also know that the commercial carriers, including Blue Cross, Aetna, Cigna, and United, have also all stated that they plan on moving over 50% of their payments to value-based reimbursement starting next year. Therefore, it's imperative for healthcare organizations to need to start creating a comprehensive plan for moving to value-based reimbursement immediately. There's really no time to waste. Just think about that. If you're not ready, other healthcare organizations in your community could steal 30 or 40% of your patients and up to 50% of your revenue. As a healthcare organization, just think if your revenue decreases by 50%, then you really stay in business. So it's one of those things where the healthcare organizations have to get moving on this today. They can't wait around, and it's important to create what I have called a 7-stage approach towards value-based reimbursement.
Okay. You know, will this 7 stages help this transformation happen smoothly? Could you talk a little bit in terms of, the goals or sort of the steps that a provider needs to look at with regard to measuring his success of transformation?
Yeah, I think we went back and looked at about 400 different Medicare ACO organizations to see what they were doing right and what they were doing wrong. We looked at the ones that were successful in getting the shared savings bonuses and which ones were not getting it. And we found a number of very important factors that I think make a difference on making this a smooth transaction.
Mark, you talked about the 7 stages. Could you talk through how those, that process will help the transition happen smoothly, and, perhaps how that would lay out clear benchmarks or stages or goals for provider organizations to measure their successful transformation?
Sure. Well, we started by reviewing the clinical and financial results of over 400 Medicare ACOs, and it was really clear that these organizations that were successful at getting the bonuses and getting the shared savings money had a number of things in common. We looked at the ones that made the money and the ones that did not get the bonuses. And it was very clear that they really need to have a care management program based on best practice clinical and financial business intelligence data, which are the performance indicators, with one centralized database of patient information across all the care sites. And that was the foundation for thriving in value-based reimbursement. And as I mentioned, we really need to have all of the data in one central database. No matter what EHR the physician or the hospital's on, doesn't matter what location they go to, including long-term care, home health, rehab, hospitals, and physician offices. We really need all of that information so we can look at everything about the patient, not just what one doctor saw, not just with one hospital or ER visit. We need all of the data. Second, we really need to be able to analyze all of that clinical and financial data with really strong business intelligence tools and graphical displays of performance indicators. Tell us how we're doing. Tell us where the gaps in care are. We need to move from data processing to the information age. Now I need to move to the knowledge age. Tell me what I need to know today to most affect care going forward and to improve overall outcomes. And then I'd say third, we really need to identify high-risk patients and get them enrolled in this comprehensive care management program. Without this, we really cannot change the healthcare system. For example, we need to know how many of our diabetic patients have an A1C value greater than 8.6 that are not in control, and then get that group of patients enrolled in a care management program with the patient and their family to improve overall healthcare costs. So we have to have the data, have the BI tools, tell me what's going on with that, enroll the patient, get the patient engaged, and then update the risk scores based on that engagement and understand exactly how we're going to reach out and touch these people. And then, of course, it'd be great to get to remote patient monitoring. You realize that 50% of the data we need to measure and monitor a patient's health is in the patient's home, and we don't collect any of that information. We only collect the data that's in a hospitalization, emergency room, and some of the physician offices, but really none of that has to do with health. None of that has to do with improving outcomes. It's all about collecting data. We need to move to the information, and I like to call it the knowledge age now, where I'm able to help these patients improve their health by having access to all of their information. It's a simple process, I think. But again, it's a process that all healthcare systems have to figure out how to move to.
So Mark, just to touch upon that last point over there. So, next gen technology like IoT, right? Your wearables are something that does allow for a lot of this information to be captured. How do you think, you know, in combination with VBR are kind of making healthcare providers sort of evolve in how they collect data? Anecdotally, anything that you've heard?
Well, Yeah, I would say that that's really what I like to call stage six
Mm-hmm.
of collecting the information in the home. So there's a lot of things that have to go on ahead of time because you really have to identify who these patients are. But once you identify high risk patients where we think there are ability to capture data from the home, I think these wearable devices or devices, medical devices in the home are going to be very valuable because we can't rely on the patient to send us data. We need to have some kind of alert that goes either to their iPhone or their intelligent phone, a Fitbit that's on their wrist, or a medical device in the home. For example, we know that if a diabetic patient gains 2 pounds from the day before, so on Monday they weigh 180, on Tuesday they weigh 182, it's
Mm-hmm.
only a 2 pound gain. But we also know that there's a 70% chance they're going to have a healthcare event within the next 5 days, which probably would be like an emergency room visit. If I know the patient gains 2 pounds, I can have the care coordinator call that patient, talk to the patient, find out what's going on, and then assess then based on a series of criteria if this patient needs to come see the doctor right away. A 2 pound gain seems very little, depending, especially the way people eat sometimes,
Mm-hmm.
but that is a major effect for people that are diabetic. If I can get that information, I can save $3,000 a year per patient just by understanding that there is a weight gain and getting proactive care for that patient instead of waiting them to show up in the emergency room. There are very good balances and values for a healthcare system to start paying for remote monitoring devices in the patient's home.
Interesting. I think, I think you've touched quite clearly on the point about how we need to monitor them better and, to look after them better. And obviously, there is a direct impact to the payer and, of course, the provider. But, with this shift to value-based reimbursement, what are the impacts, or shall I say, the changes that are happening in the life of, or in the context of the patient? How is this shift affecting them?
Well, I think no one really knows yet because today, the way these ACOs have been rolled out, a patient is already going to a doctor and that doctor enrolls in this ACO. So it doesn't change the patient to physician relationship. When we move to true value based reimbursement, where a health plan is going to award a contract to a specific health system is a definition of hospitals and physicians coming together. But that healthcare plan says now this health system wins the award for, say, 5,000 diabetic patients in this geographic area. When that occurs, that health system decides who that patient can go see. So I may be going to see Dr. Smith for the last 5 years. All of a sudden, Dr. Smith's no longer part of that health system's panel, and I have to go see somebody else. That could be very disheartening to the average patient out there because all of a sudden I'm being assigned to a different provider or different hospital that I can go to. Of course, this has been going on ever since health plans started. If you're a Medicare patient, you have to go to a Medicare certified provider. If they're no longer certified, you can't see them anymore. Aetna, Cigna, United, and the Blues already have their panel of physicians, and every year that panel might change. So we're already used to having the big insurance companies of these gigantic buildings that they're in assigning which doctors I can go to. The difference now is going to be my local hospital system is now deciding who I can go see and who I can't see. It's more localized. And I think there might be more effect of the patients. Patients want to be able to pick their doctors. But under this model, if you're a chronic disease patient, part of the healthcare plan that gets assigned to one healthcare system, that healthcare system picks the patient. And that might cause some problems. But in reality, none of this works unless we can get the patient engaged with the physicians, the care coordinators, and maybe some community resources, because the patient has to agree to change the way they exercise or what they eat. They have to get better. Because we're only talking about going after the high-risk chronic disease patients. And that's probably only 18% of the population.
Mm-hmm.
There's another 12 or 14% of the population that have chronic disease, but they might be in control. But we have to work with those patients to find ways of improving outcomes. And if the patient won't change, we can't improve outcomes. If the patient won't take their medications, the patient won't change the way they eat or different things that they're doing, they're not exercising. We can't make change if the patient does not get engaged and changes their lifestyle. That's the hardest part about this. We can set all these standards, we can set all these performance indicators, we can pay based on performance, but it has to be the patient changing the way they do things. Because if we can't change the patient, there's not going to be any change in improvements.
So, Mark, I guess that means that patient education and then engagement is a huge part of this entire system about how sort of the value based model gets transitioned finally to that end patient. Am I correct?
That is correct, yes.
Okay, interesting. And currently, the payment models are linked to hitting different metrics and different measures. Do they take into account this necessity of patient engagement, or how effective have these models been, in your opinion?
Yeah, I think you go back and look at all of the performance requirements that are out there that people continuously monitor. It's good to have a system that can measure all of the 400 plus quality measures that have been established by the government, or these different quality performance companies that recommend performance guidelines. However, I need a process that reviews all the performance criteria, but only highlights the areas with the greatest concern that affects my ability to financially survive in a value-based market. Don't tell me what I'm doing right. Tell me where the gaps are. Tell me what I can do with what population that'll help me get the best results. If I've got 100,000 patients I have to monitor, and it's good to monitor all of them, all these performance indicators, but tell me the 5,000 that I need to really watch, and tell me the 100 patients I need to contact today to get the best overall results. Because again, if I don't have a value-based contract to improve quality and lower costs on, say, diabetic patients, then it's not a priority today. The priority is on those that will affect my reimbursement. I hate to say it always, but you got to follow the money. There's a number of quality indicators out there, but I need to concentrate on those that'll help me keep my doors open. Because remember, if I can't get these contracts and I can't improve overall quality, I will lose money. And if I can't make payroll because I lost funds, does it really matter how much I can meet performance requirements? If the hospital is closed, how important is it to improve future quality and outcomes? We're closed. We can't do anything. We need to make sure we're following the right measurements, doing the right things, because, again, we're talking about a potential shift of 50% of our reimbursement we get from the healthcare plans and the government, which represents about 90% of the money we get. Yeah, we get some money from patients and some other things, but if we can't control and monitor the performance indicators on the high-risk patients, we lose. Therefore, find a system that measures all 400, but have it highlight the areas that are the biggest concern based on priority, based on contracts, and based on things that we can control. It's hard to control patients that have cancer. It's much easier ability to control the overall cost and quality for patients that have asthma, that have diabetic, that have somewhat of a heart disease. There's 5 major chronic disease categories that have been identified that quality and cost can improve if we have a strong, ongoing care management monitoring system. That's where we have to concentrate today.
Interesting. And I think you briefly touched upon it, but the way that revenue is driven by the performance metrics and by that finite population of high risk patients. With this transition happening, how has revenue actually been affected? With this entire learning and development stage, if you want to call it that, going on right now in terms of value based reimbursement.
Well, as of 2016, only 8% of total revenue has been shifted to these bundled payments, alternative payments, and value-based contracts. So it's relatively small. It might be 20% for one healthcare system and 0 for another healthcare system. So it's relatively a minor part today. It's the fear or belief that we're moving to 50% by next year, which gets everybody talking about it. Again, my organization may only be 4%. No big deal. We'll play with it. But think about Medicare is switching to this October 1st of 2017. We're talking 3 or 4 months away. All of a sudden, you can see a gigantic shift in your reimbursement. So we're not sure exactly how Medicare is going to roll it out nationwide. Right now, they've done it through the accountable care organizations. They may do it the same way. But we know the healthcare plans have already stated they're going to do 50%. And one healthcare plan stated already that they're planning on moving 69% of all their payments to a quality outcomes-based reimbursement model that we call value-based reimbursement. So we got to get prepared for it. We got to know what's going on. And we have to have more intelligent technology, much higher than the EHRs we have today, to be able to survive in this kind of market. Remember, the EHRs collect data. They may tell you what you need to do to get the patient out of the hospital. They may tell you what the right order should be for this patient who showed up in the doctor's office. But the EHRs have not been designed to provide best practices around how to keep that person healthy. They're a data collection tool that collects a lot of data. We now got to go to that next generation, call it next generation EHR, that works around the health of that patient. We don't want to replace the current EHRs that we have today because we've spent billions of dollars on that. Just think the government just spent $52 billion subsidizing EHRs. We don't want to waste that money. But I think you could put a product on top of multiple EHRs that can analyze all the data, provide gaps in care, tell you what you need to do, and then port that data back into the EHR so that the physician never has to leave their EHR. Their EHR collects data, tells them what they need to do, but also provides clinical alerts around the health of the patient in the future. That's what we really need. That next generation system ties everything together going forward around health.
Interesting. So Mark, just along the same lines, right? So when somebody's coming up with their strategy and saying, how are we going to be right on top of, value-based reimbursement because, value-based reimbursement is here to stay. How do you see things panning out in 10 years? And, so 10 years down the line, what should be the ideal system that people have in place or ideal strategy around value-based reimbursement?
I think, assuming that hospitals embrace this, health systems embrace it, and that we don't end up closing half of the hospitals because financially they couldn't survive under this model, I think we're going to have a larger healthcare reach. It's no longer going to be just waiting for the patient to show up in the hospital or show up in the doctor's office. We will have a program that reaches out to the patient, engages the patient and their family to overall improve health, just like they're doing over in the Scandinavian countries, what they're trying to do in Europe right now. It's all about improving health of the population instead of waiting them to get sick. The United States has the best medical system in the world by far. If you get sick, you're in a car accident, we are the best place to go to take care of that medical condition, that acute condition. But we are rated 19th in the world on keeping people healthy. That's because our financial system, it rewards doctors and hospitals to take care of medical conditions. They don't reward anybody to take care of that patient and make that patient healthier or control health. How can you control health when 40% of the population in the United States are going to be obese by 2020? We know that obesity drives diabetes, CHF, a number of other healthcare-related asthma, hypertension, all kind of things. But we're not doing. There's no incentive for the healthcare system to reduce obesity. We got to change that. We got to follow what other countries have done, change the financial system, and reward the healthcare providers and the patients and their family to try to stay healthier. We can't just reward the doctors. We have to find ways of rewarding the patients for being compliant with the physician's protocols. So in 5 to 10 years, I see the healthcare system moving towards more consolidated care. There's almost 5,500 hospitals out there. There's over 1,000 hospitals that are not associated with another hospital. We're going to see larger healthcare systems coming together. We're going to see more health systems that have 50 to 100 hospitals in a larger network, reaching out, having long-term care, home health, micro hospitals out there, surgical centers. We're going to move the healthcare to a model of improving the health of the population. More high touch, no longer waiting for the patient to show up. We're going to be interacting with the patient to make sure we keep them out of the hospital. Maybe more physician visits, more micro hospitals, but keep them out of that emergency room is the first priority. Keep them out of the hospital as much as we can becomes the second priority. But we need a intelligent tool, a knowledge-based tool that helps us monitor this. We need to know what's going on with the patient immediately. And that's why we're talking about patient engagement, remote patient monitoring. Patients are going to have something in their home, if you have a chronic disease, that helps us measure what's going on. We don't have to do this for all the population. We know that almost 70% of the population does not have a chronic condition today, or they're maintaining what's going on. They're not at high risk. We only need to really work on those patients that are at high risk. That 20% of the population that spends 80% of healthcare, that's where we need to spend our time. And we're not doing that today. But all this will come together. I really think by 2020 we're going to be there. Because if we're not, the healthcare system is totally going to collapse. We cannot increase healthcare costs by 818% when wages are only going up 18% during that same time. GDP cannot grow at one rate, and then we see that healthcare is growing at a 4 times faster. Something has to change, and the change is now. And I think value-based reimbursement, although not fully thought out totally right now, it's still a small percentage, now provides the incentive for the healthcare systems to work with the patients and their family to try to keep them healthier. And I think there's going to be financial incentives for the patients to engage. For example, I'm working with a couple of healthcare plans where the patient or their company or whatever, they still pay the same insurance amount. But if the patient agrees and follows the doctor's clinical protocols, I can reduce their out-of-pocket expenses from $7,500 a year down to $3,000 a year. I can reduce the patient's costs if they're engaged. I don't want to change what they pay for insurance because everybody wants to keep that equal. Everybody should pay the same amount for the insurance. But everybody has a deductible. And deductibles have gone from an average of $1,000 a year to over $7,500 a year for the deductible. That's a lot of money the patient has to pay. I need to get them engaged by giving them a reduction in that deductible if they're a chronic disease patient that follows the clinical protocols. So this whole system is going to change. Patients will be engaged and have incentives to be healthier. The healthcare plans have an incentive already to keep people healthier because it saves them money. And now the health providers, the hospitals and the physicians, the care providers out there will have an incentive to keep people healthier. That's what we have to move to. And I think we're going to be there by 2020, not that far away from today.
Interesting. A lot of the things that you're saying are true, Mark, in terms of, what we see and what we hear as well. Uh, just about the increased focus on patient engagement, and, care management, round the clock understanding of where they are and what they're doing, just especially on those high risk patients. And I think, like you touched upon it, a big part of VBR will be sort of the iterative process to get to a system where y'all are looking to preventively keep that patient healthy as opposed to waiting for him to come through an episode into the hospital. Um, so lots of things
Correct.
to happen with VBR, and I think you touched upon some of the key aspects that folks need to be thinking about. Thank you for taking out the time today,
Well,
and
yeah, one more comment I want to make.
sure.
Where do we start? I think the thing that everybody has to do is get all of the clinical and financial data in one place, one centralized database for the patients. Now, this was part of the 1996 HIPAA regulations and in 2009 part of the Obama ACA Act. which was the requirement of bringing all the data together in one location, sharing of the information. Today, from the results that I've seen, only 6% of all clinical documentation is consolidated in one place. That means 94% of the clinical data and financial data out there is still roaming around, not centralized. First thing, every healthcare payer, plan, provider, hospital, whatever needs to do is find a way of bringing all of the clinical financial data together, combining the clinical data from all of the different EHRs, because there is no one EHR out there. Every community may have, typically we've seen, every community has up to 25 different EHRs in the community, besides the hospital, the doctor, home health, long-term care facilities, rehab facilities. There's a lot of things that are out there. I need one place for that. Healthcare systems, to thrive in the value-based reimbursement, first thing they need to do is consolidate all that information and have a very strong enterprise master patient index, so we're able to identify we got the right patient, with a really good cleansing system to look at the data to make sure the data is accurate. Not to have an A1C value of 1 and the next day A1C value of 9. We need to cleanse that data. We need to have the data in one place so we can create knowledge from that. You can't do anything without bringing the data together. It doesn't do me any good to have 40% of the information about the patient and leave out the other 60% because it's in somebody else's EHR. Health organizations, get all the data in one place. That's the first step. Then we can move forward with that. But without that, nothing else will work.
Great. Mark, I think we're coming towards the end of our time here today, but again, just to quickly summarize, uh, integrating the data and having it all in one place, and then managing the care and engaging the patients, I think are three main takeaways that I have from this conversation with you today, that folks who are working in the VBR system or running a healthcare organization definitely need to think about. Um,
Yes, and we've created this model called the 7 Stages of EBR,
mhm.
and I think every healthcare organization needs to look at those. There's 40 functions underneath that within these 7 stages. They need to look at that and get prepared for that and compare the software vendors they're talking to all 40 of these steps, because if your software vendor only does 5 or 6 of these steps, you're not going to thrive in this market. Within the next 3 to 5 years, you will need a program, an internal system, your software with your processes that covers all 40 steps to be able to thrive in this market. And that is so important. It's not just getting the data together. It's not just analyzing the data. It's not just having a patient care coordination program. It's 40 aspects of it. And that's what organizations need to review, evaluate, and decide how they're going to get there in the next 3 to 5 years. Where steps 1 through 3, you need to get there today to even be able to keep your doors open in the future.
Great. Lots of learning from today's call, Mark. Thank you so much, and thank you everyone for listening to us today. For more information on Innovaccer, visit innovaccer.com. That's INNOVACCER.com, or follow us on Twitter @Innovaccer. And for more information on Mark Anderson's 7 stages of value-based reimbursement, do visit his website, theacgroup.org.